The original work was looking around the evidence from a more scientific basis, like real studies where it's a trial, where there's outcome data collected, not just, I don't think pharmacists should prescribe, somebody said it in MJA as an editorial. So actual trials where they've, had pharmacists prescribe, or dentists, or, non-medical prescribers. So we were involved in a project with National Health Workforce Task Force, which is the precursor to Health Workforce Australia, where we looked at the literature to find actual evidence. And so we were just basically saying, well, what is out there to support people who aren't medical being able to actually prescribe? So where's the evidence to say that it's safe, it's effective, they can actually do it. And so the report that's formed the basis of this current consultation's got the results of that. We were doing that at a time that was fairly politically hot, for want of another description, which made the report fairly complex to do. It was when optometrists, nurses and midwives were being given access to the PBS, so it was fairly politically hot, sort of, as well as interprofessionally fairly controversial, and obviously the medical profession had quite a lot to say about that access being granted to other professionals. But the flip side of it is that there's fairly good evidence to say that it is safe, that it is effective, that giving broadening of access to prescribing rights to other professionals within their scope of practice, so within limitations on what their training and background allows, actually can improve access to medicines and can make the health system more efficient. So the current consultation is basically out there to ask people to have a look at the report and the recommendations, and in that we suggested 4 potential models for non-medical prescribing that would capture current practice, and some other recommendations around things that would need to happen to allow that to work in Australia, based on what other people have found overseas and what's currently happened here, and some of the limitations based on what happened when optometrists and nurses were introduced, and asking people what they thought about that. Obviously the medical folk have voiced their thoughts about the fact that nobody other than doctors can do it, which is, I think, a little short-sighted, because they can't be the panacea, they can't be everything to everybody, and I think there is enough evidence to suggest that we have a lot of highly trained and underutilised health professionals within the health workforce, and there's a lot of patients that aren't getting appropriate levels of access to care, and medical practitioners are very good at diagnosis and certainly managing complex patients, and they should be given an opportunity to do that. And there's a lot of management of chronic disease patients that other health professionals could contribute to, as one example. So I think looking at models to do that is what Health Workforce Australia is really interested in. Yeah, for sure. I mean, within non-medical prescribing, there's probably 2 roles for pharmacists. There's the role as a prescriber, and to be quite frank, you're looking at probably a limited group of pharmacists who would say, yeah, look, I'm going to take up that role. And if you look at evidence from overseas, you'd say maybe 10 to 15% of pharmacists may opt into that kind of role. So it's not a huge amount. There's about 26,000 pharmacists in Australia, so maybe 2,000 or 3,000 pharmacists. So it's not going to be every corner pharmacy. And to be honest, you really need to have a separation of prescribing and dispensing, whoever's doing it, except for some situations where you know, for whatever reason you can't, you know, rural areas, emergency situations, whatever, you know, there's caveats to that. But in general, whoever writes the script, that there should be somebody else dispensing it. So in that situation, the pharmacist's traditional role as the second check, as the dispenser, as the person who's using their drug knowledge to ensure that whoever's written the script has picked the right drug for the right person, remains. So we continue and will continue to have a really critical role using our drug knowledge and knowledge of patients and their histories and our relationship with them about their medicines and their diseases to say, okay, physio, yep, thanks. Yep, did you know that this person's also taking blah, 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 maybe this would be a better choice. So I agree. I think pharmacists, you know, will continue to have a really big role in that area. And, you know, should have an expanding role as more people come on board. We should be used as a resource, definitely. So we'll never be out of a job. Or we should never be out of a job. Because we have that unique knowledge. You can look up a book, but it's the knowledge to be able to interpret the information in that and what it really means for a patient. You know, it's the difference between being a master chef and a home cook, I think. You can read the recipe, but who can make it?